consent for children in our care. And my name is Dr. Anita Khetpal. I go by Dr. K. Most call me that. I'm a child and adolescent psychiatrist working with South Canada DSS. And we are here to talk about medical consent for children in care. This is a topic that when I joined the agency, I had a lot of questions, and others had a lot of questions. So I decided to do something about helping clarify those questions and realized we need a lot of policy changes in order to do that. And the purpose of these policies is really to not only provide a better oversight for children in care, but also to provide more clarity and kind of more consensus guidelines as to when and how to provide consent for medical care for children in care. So it is really to support the medical providers, our frontline staff, and above all, our foster parents and caregivers. So with that being said, learning objectives. That'll be our next slide. And basically, we will be explaining the policy and procedures for providing informed consent to medical care and psychotropic medications. And we will be covering three major topics here: routine medical consent or consent to routine medical care, providing consent to psychotropic medication, which we will talk more in detail about, and providing consent to major medical care. So I'm going to go through some definitions and overview what is legal custody. So when a child comes under DSS legal custody, it is really the physical custody, the care and control of the child or youth who is in the care. And this helps us determine where the child or youth lives. And it does also include the right and the duty to provide protection, food, clothing, shelter, but also ordinary or routine medical treatment, including, of course, education, supervision, and discipline of the child or youth. And in an emergency, to authorize surgery or other extraordinary care is also included. I do want to stress here that unless otherwise provided by court order, the parents have the right to make decisions affecting the child or youth, including consent to medical care. So parents are the ones to make decisions on behalf of the child or the caregiver that is kind of the legal guardian. Now, DSS has the ability to make healthcare decisions for children and youth in foster care, and this is provided by the court order. So we'll be talking more about that as we go to the next slide. So what is the overview of medical consent? For children in foster care, like we said, DSS typically has authority to consent to routine medical care by court order. And I want to differentiate that from major medical care consenting. So usually the court order gives DSS the authority for routine medical care. The court order does have a language that gives DSS the authority to consent to medical treatment and be designated as a child's personal representative as set forth in HIPAA regulations. Next slide. Now, this is kind of a topic very dear and close to me, informed consent. This is basically based on shared decision-making, which has better outcomes as it provides better compliance and engagement for the caregiver. And this is the process by which a parent or a consenter, be it primary or secondary as we define it in DSS, agrees to treatment after a medical provider has fully and clearly informed the consenter about the proposed medical care, including the diagnosis and what the treatment is being provided for, and any alternate treatment options, and going through the risks and benefits of the treatment, as well as what may happen without treatment, and what are the risk benefits of alternate treatment options. So this is based on moral and legal premise of patient autonomy. So keep in mind, a failure to do so will be kind of counted as a battery to the person. Now, there is a concept of implied consent for physical exam, but basically, this is the moral and legal premise of patient autonomy that we all doctors were taught that we had to provide the information to a person consenting to treatment in the language they understand clearly before they make a choice whether they are going to consent to that care or not. So they have the autonomy and the right to do so. And our job is to provide them that information so they can make appropriate decisions. Next. So, who is the consenter for care in DSS? The primary medical consenter, we are going to talk about primary and secondary medical consenter, but the primary medical consenter for routine medical care for children in foster care is either the case manager, supervisor, or the regional clinical specialist. And I will go to the next slide. So what is the role of the primary medical consenter, the case manager, their supervisor, or regional clinical specialist? Basically, not only they provide consent, but we strongly encourage in our agency that they engage the parents or guardians and the child or youth in healthcare decisions, unless doing so is not in the best interest of the child or youth, and that the consent is given voluntarily without undue influence. In other words, there's no fear, no intimidation, and also that when informed consent is obtained, that the providers are not, are basically giving them accurate information so they can make right decisions based on the diagnosis, their options, and risk benefits of each treatment option that is available. And what happens if they don't consent to treatment as well? Now, the primary medical consenter may give verbal consent by phone at the time of appointment for psychotropic medication, followed by completion of psychotropic informed consent form. And this, we have it here because this comes up kind of what if the case manager is not present at the appointment, or the secondary medical consenter is also, for whatever reason, not available. So we wanted to be sure that you were aware of this option as well. Next. So who are the secondary medical consenters and how this came across? We had it where sometimes foster parents were consenting to care for our children when they were not designated as consenters. Remember, we talked about that the court order gives DSS the authority to consent to routine medical care, not the foster parent. But we had it where foster parents were taking children to appointments and sometimes consenting and sometimes not. So we wanted to have a process here where when, whoever is available at the time of the appointment to see if they can be designated as secondary medical consenters. So there is no, hopefully, delay in providing treatment or that routine medical care. So in the absence of Child Welfare Services case manager, supervisor, or regional clinical specialist, DSS may delegate authority to consent to routine medical care. And these would be the secondary medical consenters, who are typically the child or youth's caregivers, such as foster parents, it could be relatives, it could be pre-adoptive parents, and professional employees of emergency shelters and group care providers. I do want to make a distinction here that staff of psychiatric residential treatment facilities cannot consent and cannot be designated as consenters. And certain other people, even in the group home, is really the professionals like nurses and care coordinators, not the people who would be transporting the child or youth to the appointment. And the form that DSS uses to designate the secondary medical consenter, it's DSS form 2055 or South Carolina DSS designation of medical consenter form. Next. So what does a secondary medical consenter, what do we kind of want them to do? Not only we want to be sure that they are consenting only to routine medical care and that they have also completed healthcare oversight training that is provided at this time through South Carolina Foster Parent Association, and that they are giving copies of Form 2055 along with placement agreement to the medical providers so they would know that they are the secondary medical consenters. And also that after they consent to care, that they are providing after visit summaries to the child and kind of uploading it in the CAP or Child and Adolescent Information Portal, or sending it to the regional nurse. And these are their contact information for the regional nurses. Next. So this is what the form looks like. I just wanted to be sure that you all were familiar with this form so you would know what to look for once a child comes with a foster parent, and their name would be there, and how long this form is valid, and the DSS licensing representative signature would be there, so you can be kind of aware that they've been designated as secondary medical consenter. This form is usually valid for 1 year from the date of the training that they took. And so basically, you want to look for this form, and it also outlines on this form what is some of the routine medical care. If you kind of look at the end of the form, that is kind of like immunizations and hearing screening kind of tests, vision tests, mental health evaluation, and psychotropic medication is also included on it, but it does in addition require filling Form 2056 that we talked about. So basically, they are to provide you this consent form to let you know they can consent to care for children that are in our custody. Next. Okay, so this slide in particular, now a lot of effort went on to create what is on this slide in the policy, because one of the big questions that came up, what is routine medical care? We had to do a lot of research and narrow down based on what other states were defining, because really there was not a clear definition or, clarity on this concept. But generally, we knew that this was like, EPSDT or early periodic screening, diagnosis, and treatment that we wanted to define into routine medical care, or these are called well-child exams. Lab testing and X-ray examination is also included. Dental exam and procedures, including cleaning, filling, and braces, and age-appropriate screening, testing, and immunizations. Vision and hearing tests, as we talked about, developmental assessment, trauma screen, and physical speech therapy, occupational therapy, dietetic services, and mental health assessment that we talked about. Next slide. So what is major medical care and who consents to that? So unless the court order indicates the parent or guardian have the right and duty to authorize major medical care, and they retain that. And so if a child has major medical care or surgery and they are in the legal custody of the department, the parent or legal guardian still have the authority to consent to that. The case manager must make diligent efforts to engage the child's parents to make a decision whether to authorize major medical care and surgery. And in instances where parents are not accessible, DSS may obtain a court order authorizing the agency for major medical care or surgery. So we would have to go through the court order unless the court order has given us the authority for this as well. Usually the court order gives us authority for routine medical care. Next slide. So what we define as major medical care, this is kind of something which is extraordinary, non-routine care, of course, including surgical procedures, invasive diagnostic procedures, anesthesia, any treatment the child or youth's physician considers dangerous or threatening to the life or the admission to inpatient mental health or substance use treatment program, chronic opioid analgesia, end-of-life decisions like do not resuscitate, abortion, ECT, aversion therapy, and any experimental treatment or clinical trial. The designated secondary medical consenter does not have the authority to consent to major medical care. So we again want to stress that it's that really they can only consent to routine medical care or ordinary medical treatment. Next slide. So another topic kind of dear to my heart is the psychotropic medication oversight. And this been there since 2008 when feds had the first regulation, Fostering Connections to Success and Increasing Adoptions Act of 2008, which required that the state agencies have oversight of prescribed medications for children in care. And this was further strengthened by Child and Family Services Improvement and Innovation Act of 2011, which required specific protocols for monitoring of psychotropic medication. So some of what you notice in our policy and procedures is coming in kind of reference to these protocols that we are required to have to kind of make sure that the use of these medications is safe and appropriate, and there is an oversight and clear guidelines as to our staff, how they can provide that oversight. And this, of course, improves the outcomes for children in foster care and also comes under the healthcare oversight and coordination that we have here at the agency. Next slide.
Dr. Ketpal, this is the 5-minute warning.
Oh, good. Thank you. So psychotropic medication does require DSS Form 2056, psychotropic medication informed consent form to be, provided. It's again based on the informed consent that we talked about. And the medical consenter should further make sure the consent is given voluntarily and without undue influence. Next slide. So the psychotropic informed consent form again goes through the elements of informed consent, where the prescriber has talked about the condition, symptoms, diagnosis, the benefits of treatment, and basically gone in depth through the informed consent that we already kind of went through. Next. So this is what the form looks like. And as you can see, it's not very complicated to fill out. Basically, you have to put the child's name, the date of birth, which can be done by the case manager or the provider, and you write the name of the medication and the diagnosis, target symptoms, benefits, the dosage that you would like to get approved for that child's age and weight, and to indicate whether this is a new or the old medication. Now, this consent is required for new medications. I just wanted to be sure to kind of go through that. So this can be done by the primary consenter, which would be the case manager or the supervisor or regional clinical specialist, or the secondary medical consenter can also sign this form. But after they sign it, they have to share it with the case manager so they can upload it in the CAPS or internal record system. Next. So one thing I did want to stress and bring to everybody's attention, there is a hierarchy of approval. So if a child has one of these 3 red flags, then case manager and our supervisor would not be able to consent. Neither would be the secondary medical consenter. They have to reach the case manager, and the case manager in turn reaches our regional clinical specialist for approval if a child is very young, like age 6 or under, child is getting 4 or more psychotropic medications prescribed, or an antipsychotic is being prescribed. At that kind of, we tell our case managers, primary and secondary consenters, that they can let the provider know that they can write the prescription, but that they would be reaching out the regional clinical specialist to get the approval, that the medication cannot be given until that approval is obtained. Next slide. So DSS does not, under any circumstances, authorize the withdrawal or withholding of life-sustaining procedures, and change a child's, do not resuscitate when parents have not been, rights have not been terminated. So we cannot do that, in other words. When parental rights have been terminated, there is an approval process that kind of talks in depth about it beyond the scope of time we have today to talk about it. So I'm going to go to the next slide. So in an emergency, the parent or guardian decides whether to provide informed consent to major medical treatment unless the parent is unavailable or it is not in child or youth's best interest for the parent or guardian to consent. If the parent or guardian is unavailable or it is otherwise in the child or youth's best interest, a county director or regional adoptions administrator has the authority to provide informed consent with DSS. Consent, if given again, should be voluntary. Next slide. So that was the emergency medical care, and that kind of brings to me to the conclusion of the presentation, and I will let Shoshana talk about how you all get the CME credit and attendance.